So now let's talk about the 3 months and beyond in terms of monitoring. So what is the role of monitoring? I think this is a big question a lot of people ask, because believe it or not, there's a lot of people who don't monitor, but how is it important, and what do I mean by monitoring? And should we be paying attention to national and international guidelines in terms of response to therapy, and why? So these are my disclosures, and just to point out that I'm not going to discuss which is the best drug in any situation here, but I do work with every company that makes a drug in this area, so hopefully I can talk from experience in all these areas. And I am a member of the European Leukemia Net Guidelines Committee, so I have some experience in establishing some of these guidelines. So you saw a similar slide earlier today with some other drugs, but this is CML. And if we look back to almost 150 years ago, we have an old friend who's rematerialized in the last decade in terms of a therapeutic efficacy, right through to busulfan, interferons, transplants, which Jerry will talk about in a few minutes, to tyrosine kinase inhibitors. But what's interesting about CML is the whole drug development is run in parallel with understanding the biology of the disease. And I think this has been a hallmark for how we're going to be treating all malignancies in the future. It's not the shotgun approach with a drug you extract from some leaf you pull out of the Brazilian rainforest, but you actually understand the disease and rationally design inhibitors, which hopefully will improve the efficacy and will reduce the toxicity. And as you can see from the finding of the Philadelphia chromosome now about 55 years ago, now right up to molecular monitoring and mutations, we're beginning to understand a lot about this disease. You saw a similar slide earlier with CLL, but this is again MD Anderson data, and you can pull the same thing from the German group, showing the improvement in survival with CML with decades. And this is with aggressive interferon therapy, but this is what's happened since imatinib came into existence, and it's totally changed this drug. So why monitor? Well, number one, to look for optimal response. Two, to look for toxicity. We do have options for therapy, both in terms of the drugs available and other modalities of therapy. And something which perhaps is not always looked at, but we do prescribe extremely expensive drugs. So we need to use resources wisely. And I think coming from a country where most of the patients get their drug through the public healthcare system, this becomes a very important issue. But I think most importantly, I think monitor is another way of measuring compliance. And it's very much like looking at the glycosylated hemoglobin. Although we can't measure levels of taking a drug, you will know whether someone's taking it based on routine monitoring of their molecular response. So monitoring of CML, well, the cost is much lower for monitoring than it is for the cost of the drug. In fact, we calculated the cost of monitoring even monthly is less than the cost of 2 to 4 weeks of imatinib, and the other drugs are even more expensive. It helps optimize treatment. You know, you don't want to monitor too often. I don't think this helps anybody except the insurance companies who pay for it. And optimal monitoring affects life. It means if a patient is doing well, they do better. And I think this helps both in terms of who's paying the bills and in terms of their quality of life. So we do have a lot of options for therapy. There are 3 frontline drugs approved in most places, and imatinib, which goes generic in the United States in January, will put at least, what my understanding, anywhere from 6 to 10 generics on the market by January. And that's really going to plummet the cost of the drug. For salvage, we have the 3 drugs we use here, although we would rarely use imatinib for salvage. But we have additional drugs like bosutinib, ponatinib, which was discussed, amacitaxine, and interferons. And this is not something that we've thrown out with the bathwater. In fact, I have 3 patients on this drug right now, all of whom are pregnant, and it's being used to control their disease while pregnant because all the other TKIs are all teratogenic. And we have drugs that are very good still in palliation. And busulfan, of course, particularly intravenous, is of value in allografting. And Jerry's going to talk about allografting in a few minutes, but half my life is spent still doing this, and I think this is still a very important feature of the management of CML. Now this, I think, was one of the most exciting talks, and it was relegated to a poster at the last ASH meeting, but this was results from the MD Anderson. And basically what Jorge Cortes said and presented in this poster was that if you take newly diagnosed patients with chronic phase CML and balance them out by age and comorbidity, their survival is equal to that of another individual with the same age and comorbidity. So what in fact I'm saying is people are not going to die from chronic phase CML anymore. They're going to die from everything else, including other malignancies, the cardiovascular events that you've just heard about. So I think it now behooves us, in particular the primary care physicians who tend to figure, oh, the patient's got cancer, let's not bother anymore, now to focus in a little more on being more aggressive about treating the hypertension, the diabetes, and all the other issues. And that I think you find to be a problem, I sure find a problem, that I just can't get the primary physicians interested in some of these things. So we're fortunate now, we now have a cardiovascular clinic just dealing with CML patients on TKIs. So managed patient with newly diagnosed chronic phase CML, then they will live long. And I actually wrote this about a week before Leonard Nimoy died. This wasn't done intentionally. And I decided after that I would leave it in. And I think the future therapy, I think we're now looking at remission-free events. There's now at least 4 or 5 big international studies and a number more on the way which are actually showing that there is a significant percentage of people who respond well to TKIs who in fact may be able to stop their drug permanently. I think it's something we have to look forward to in the end. You know, for those of us who talked about cure being functional in the past, now we're talking about cure being real, meaning no CML, no drug. So how do we monitor CML? Well, a number of different levels, right from the hematologic response, which is the crudest, the cytogenetic response, which is great, but it does involve having to do bone marrows. FISH, which is actually a molecular rather than a cytogenetic response, because you're actually using probes for the molecular test. And molecular response. And this is a big issue, because I think the molecular response, although I favor it, and there is international standardization now, which has now put this on the level of something like doing the INR, and there are now World Health Organization standards which have gone up to companies making secondary standards. I think making sure that an individual has access to good reproducible molecular testing is a real issue. And this has been a problem, particularly in places outside of major academic institutions. So this is, I think, where we really have to do some work. So this is why we're looking at disease burden. As the disease burden is higher, and we start to improve, the disease burden goes down. But at roughly the level of detection in a good lab, we still have a significant amount of disease below that. But as we look at the so-called log reductions or standards, which are anywhere from 10%, 1%, 0.1%, we see improvements that can be picked up with routine monitoring. So which monitoring do you use? Well, the first thing I tell people is go for quality. If you do not have good molecular monitoring where you are and it's not reproducible and you can't tell from one moment to the next whether you're getting an improvement or a loss of response, don't use it. Go with FISH or something that you know you have the quality. But if you have access to good quality and everything, then go for sensitivity. And this is where molecular monitoring is obviously the most sensitive of all the testing. And go for convenience. Molecular monitoring is easily done in peripheral blood. In order to do cytogenetics, this is a bone marrow test. And most of my patients, and I'm sure all yours, don't particularly appreciate this kind of a test if you don't have to do it. So the 2 major international forms of guidelines are out there, the European Leukemia Net and the NCCN. This is a summary slide based on looking at things at the various periods of time or landmarks. And really what we're starting to look at is number 1 at 3 months, this so-called 10% molecular, or it was a 65% response by cytogenetics. And this is now coming up to be a term that you're may not have heard, but it's called EMR, the early molecular response. And this is something that's going to be appearing more and more. And this is highly predictive of how someone is going to do. Follow that various other things like whether they get higher molecular responses or complete cytogenetic response become very important as we get further out. We do know that probably getting an MMR is the minimal we want, Although we do know that there are people who are out at least 3 years, and if they haven't progressed and have got at least a complete cytogenetic response, actually the progression rate is pretty good even in those individuals. But that's beyond the first 3 years. This is ELN Guidelines, and we do look at failure, and failure is not achieving this so-called EMR, or the cytogenetic response, early. Definitely by 6 months. There's some big controversy. Some people say you can wait for 6 months. By a year out, you should have at least a complete cytogenetic response or a 2-log reduction or a 1% reduction on the international standard. And after that, we're looking more to get to the 0.1% range. Very similarly, in the NCCN guidelines, we looked at areas where predictive. Now, the NCCN talks about changing if you don't hit EMR. The big issue here is none of us know what to do with those individuals who don't hit EMR. There's only really one study out that's out that in any detail, and that was the Australian Title II study, and they actually didn't show much of a change in survival in a shift from imatinib to nilotinib. So this is a bit of a black box with roughly the anywhere from 8 to 10 or 20% of people, depending on which drug you use, who may not get EMR. And this is the basis for a number of studies that are going on, including the most recent United Kingdom study, which is actually looking at putting these individuals on ponatinib after they fail an upfront second-generation drug. So this is NCCN 3-month guidelines. Already, if you get EMR, you continue. If you don't get EMR, they should monitor these people very carefully and consider a second-generation drug. Now, if you have started with a second-generation drug, that's another issue. Now, this is some of our own data. And really what shows is if you have EMR by 3 or 6 months, people do extremely well. It's this group of individuals who don't get this EMR by 3 months who don't do quite as well. And again, this should be a target for experimental treatment. Now, what we do with these, I don't know. Are they so badly off that I would jump to allografting these patients? Which, no, I don't think they're that badly off yet. But they're someone who perhaps you should be following pretty routinely in terms of their molecular testing. Again, this is looking at the 6-month, and it says very much the same thing. Mutation testing. This should be triggered by a failure to reach a milestone or a loss of response. Routine screening is pretty useless. Definitely shouldn't be done at the start of treatment because it doesn't predict anything, and it's expensive. Testing level is open to debate. There's a lot of literature out there about looking for techniques that are sensitive at 1% or 0.5%. But basically, a 15 to 20% mutation rate is pretty predictive that that mutation is in part responsible for the loss of response. Now, you've seen this in part. These are the basic drugs. This is ponatinib. This is a drug which is no longer in development. It was a non-TKI. And again, it's the red is bad, green is good situation. I think with a series of mutations down here. And this really shows that you have, for the most part, a lot of variety in terms of a patient who may be resistant to one of these drugs based on mutation may very well be able to be switched to another drug. So I think it's important to know that just because someone has developed a mutation, all is not lost. So what will be beyond 3 months? Well, compliance. Now, this was an interesting study that was reported now about 5 years ago. Many of you I don't know about the BEM system. What this really is a pill bottle with a computer chip in the lid. This was a study done at the Hammersmith in London, England, by David Marin, who is actually now a transplanter at MD Anderson. And what it did is it actually records when the patient opens the bottle and how often. And what they did is ask patients if they missed drugs, counted pills, and then did this. And boy, was there a big difference, to the point where if you, this was the probability of achieving a complete molecular remission, which is roughly what we call MR 4.5 these days. But if you adhered to the drug, meaning you missed 2 or fewer doses per month, you did extremely well. If you missed more than 2 a month, you didn't do as well. So it doesn't take much. And I think this kind of fine terms of adherence and how people do is not just CML. We find the same thing with tamoxifen. We see the same thing with hypertensives. We've seen the same things with anti-hyperglycemic. So it's a big issue. And I think that study which they did actually demonstrate that your patient, for whatever reason, may not be telling you exactly what is going on. Long-term response prediction. Well, this is the original IRIS study, and you saw some variations on this. This is one of the most recent updates, which really showed if you got at least a EMR, people did relatively well. If you didn't make the 10%, the event-free survival was much lower. We do know that with second-generation drugs, as pointed out, the chance of getting deeper response is very good. This is with dasatinib, similarly with nilotinib, they do much better. Now, deeper responses, faster responses means less progression. It did not translate into much of a survival, if any difference. What it did do is get more people to a level where perhaps they will be able to stop treatment successfully down the line. I think that's perhaps the most important aspect of this at this time. This is discontinuation. This is the first of a number of different studies. This is the French group, which really showed with low so-called patients who were on imatinib for more than 5 years and got at least what there was undetectable disease, which was close to a 5-log reduction. They showed about 70% of these people could safely be discontinued. And then virtually everyone who recurred within the first 6 months. So that's the other big message here. If you are considering stopping people, you should be monitoring them with molecular testing monthly, because the ones who fell off the curve, if the drug was restarted, virtually 100% of them can be salvaged. But if you wait 3 months, it doesn't work quite this well. So what's happening in the real world? And it's nice for us to sit back in our ivory tower academic institutions and tell everybody else to do, but what really goes on? I think there's 2 studies out there. One which looked at community physicians primarily and how they treated it. One is from Contargian that was published a couple of years ago, and one that is published online by Stuart Goldberg, who some of you may know. He practices just across the river in Hackensack, which actually looked at a number of physicians out there as to what they want to do. Now, these slides are detailed. Do not pay attention to the actual number in there, but I just want to show you some of what's going on. Is number 1, attitudes towards guidelines. Now, generally people agreed with guidelines, but surprisingly enough, there's some who somewhat agreed, and there's even a few who were ambivalent or didn't agree at all for a number of different reasons. Secondly, a number of different things as to the fact that these had an impact on patients. There were barriers to using them. There are a lot of barriers to using them, and a number of people find. I don't know whether they didn't specify what these barriers are, but I think, I guess if you have a lot of CML patients and don't see this very often, to try and remember necessarily where someone is failing is not necessarily that easy. And thirdly, easy to find on a database? Well, you know, going through those NCCN tables in my mind's always been a little difficult. And I'm not the only person who does that, and I don't use the NCCN. But a lot of people actually found them difficult to use. They wanted special training courses. Now, this is from Contargian's group. What's our endpoint in treatment? Well, about 3/4 of patients said they wanted an MMR or 3-log reduction or CMR, and they broke down accordingly. But even this wasn't agreed about anybody. But you want to know something? When we sat in the ELN committee just a couple of years ago deciding what we would base things on, there's about 30 of us, and the room was split about half-half, thinking whether we should go for MMR or whether our goal should be MR 4.5 and stopping. And even the, quotes, experts couldn't agree on this particular event. I think if your endpoint is trying to stop people, you've got to get to CMR or MR 4.5. If you want to give them nice, healthy lives, but on drug, well, MMR is a pretty reasonable endpoint to look for. And again, when to look? People just didn't know. Do you look at 3 months? Do you look at 6 months? Do you look at 12 months? Well, the guidelines there, I think the 3-month, as I said, is very predictive, but you need to be monitoring them on a regular basis so you don't send them off for a year and tell them to come back. They need to be followed on a regular basis. And when is therapy not working? What are the criteria for not working? It's all over the map. It's very inconsistent as to what. You know, I think not working is basically, are you getting side effects which may be stopping the patient from taking the drug regularly, or are people not meeting milestones or losing responses? But boy, a lot of different variations on what is guidelines. So they're not easy to use, but it becomes an issue. So conclusions, I think monitoring consistently is important because it helps determine the optimal response. It tells you when it's time to cut bait and run with whatever drug you're using or any drug. It helps determine adverse events, and I think in my mind monitoring is more than just doing a molecular test or cytogenetics. It's talking to the patient about side effects on a pretty regular basis. I think the other thing that comes into play here is we're not the only people who actually take care of our patients. There are other physicians who may be taking care of their hearts or their rheumatic diseases or something else. And in fact, they may be started on other medications which may in some way interfere with the therapy. And we may be able to select patients who are eligible for treatment-free remission protocols. Predicated, however, on understanding these tests. So we really have to understand what the molecular monitoring report that we get actually says, or what they suggest. Understanding the quality of the test that's available to you. As I said, if it's not a good test, you may not want to use it. And understanding the established guidelines to help with treatment decisions. And with that, I'll finish.